Well, good morning, everybody. My name is Dr. Paul Tern, and I'm one of the senior residents in the Department of Cardiology in the National Heart Centre Singapore. And today it's my pleasure to give you this talk on cardiac screening in asymptomatic individuals. What's the evidence? So let me just start with a caveat that this lecture is only if you are asymptomatic. It only pertains to you if you are asymptomatic, and if you have any symptoms whatsoever, chest pain, shortness of breath, etc., go and see a doctor. So with that, we start off with a clinical vignette. So here's a chat between two people. Boy, are you free to talk? Yes, what's up? My cousin's friend's Ahmad's cat's vet got a heart attack. Now I'm very scared. How? Should I go for medical screening? I found this package. They say they'll check my heart gao, do comprehensive scan. But do you even have symptoms like chest pain or something? No, but I'm scared. Okay, how much is it? $1,000? Wow, expensive, but I'm scared. So how? Do or don't do? And that's really the question we're facing today. Do or don't do? What is the evidence for cardiac screening for asymptomatic patients? So because we're cardiologists, we like to look at the evidence. And in fact, this question was precisely answered by one of the trials, which was done by the Danish, by some other cardiologists in Denmark. So this is a Danish study. It was conducted between September 2014 to 2017, and it looked at men between the ages of 65 to 74 years old. And there were no exclusion criteria, so anybody in any state of health could apply for the study. So they took these patients from the Danish Central Registry, 46,000 men, and then they offered 36.1% to be screened. Of the people who were offered screening, 62% of them took up the offer. So we'll go into what the screening measures they did subsequently, but importantly, those people for whom positive findings were detected were treated with appropriate lifestyle interventions, medications, and surgery. So what kind of cardiac screening did the Danish investigators do? So they did this ECG-gated CT, which means that they put some leads on your chest, and then they did a whole scan from the top of your head, from the jaw, all the way onto your thigh. And what that's looking for is, firstly, coronary artery calcium, which will be talked about more in a separate talk, aortic aneurysms, and then subsequently, they also did these measurements of the blood pressure in your arms and your legs, looking for peripheral vascular disease. And with the ECG electrodes, they could detect atrial fibrillation, which is an irregular heartbeat. And finally, they did some basic blood tests to look for hypertension, high blood pressure, cholesterol, and diabetes. So blood pressure measurements for the high blood pressure, and then blood tests for cholesterol and diabetes. And here you can see from the trial diagram that, I draw your attention to the right side, if they found any positive findings, which means any problems at all, then the patients were referred on to see their cardiologist and relevant interventions were started. So like, for example, aspirin was initiated, that's a blood thinning medicine, control of cholesterol with statins, patients advised to stop smoking, and given some dietary advice. But how did the patients do? And here on the left, you can see that basically this is the time to death for patients who are screened in red, and in blue, those who didn't undergo screening. And there's no difference whatsoever. So let me just read to you the conclusion from this trial. In this population-based randomized trial, older men who were invited to undergo comprehensive cardiovascular screening did not have a significantly lower risk of death than a control group after a median of 5.6 years of follow-up. Screening does not help? Well, actually, I think we need to put a finer point on this. Screening does help, but only if you are looking for the right things. And we'll talk about what we mean by the right things later. I think it's important to also consider what's the downsides of screening. First of all, can you get false reassurance? So that's when the test tells you that maybe there's no severe blockage in your heart arteries, but actually you are still at a risk of developing a heart attack. Or maybe the tests are not perfect and then you can get a wrong diagnosis. Or you can even get overdiagnosis where they pick up something that might not actually be a problem at all. For example, a slightly abnormal blood test or a spot in your lungs. And then you go and you end up over-investigating, wasting money, causing you unnecessary anxiety, and even wasting healthcare resources when actually it wasn't something to be worried about at all. So if screening is maybe not the answer, what then is the answer? So before we go into all that, let's take a step back and let's consider what actually causes heart attacks and death. Because at the end of the day, I'm sure that you're here listening to this talk because you're worried about your risk of heart attack and your risk of death. So the risk of heart attacks and death is very strongly linked to this process called atherosclerosis. And what atherosclerosis is a buildup of, as you can see in this artery, this yellow, very fatty, and sometimes also calcified plaque, which ends up blocking the artery progressively. And what causes the buildup of this plaque is things like smoking, age, high blood pressure, cholesterol, and diabetes. And we'll keep coming back to these same risk factors over and over again. And then one fine day, when there is a break in the plaque, then it exposes all this fatty material to the blood forms a clot, and then you get an acute heart attack. So then who is more likely to get this heart attack or any adverse events? Is it this man on the left with a 70% blockage in the middle of one of his heart arteries? Or is it this other man on the right who doesn't have this, what we call significant blockage, it's more than 70%, but actually has a lot of all these like very lipid deposits, these fatty deposits all over his body, all 30%. Who is more likely to get an adverse event? Well, actually, it's this man on the right. And it's the total burden, I'm going to repeat again, the total burden of this fatty deposits, atherosclerosis, that is the greatest predictor of cardiovascular risk. So then this begs the question again, if it's the total burden that determines the risk, how do we assess the atherosclerotic burden? Well, the best way we can estimate the risk and assess the total burden of disease is by looking actually at your risk factors. So as I said, age, smoking, diabetes, blood pressure, and cholesterol. And these are the principal factors, the underlying factors that drive this problem of fatty deposition in your arteries. And because we have other studies that have looked at big populations of patients and looking at the correlation between these risk factors and the amount of atherosclerosis they have in the arteries, we can then calculate a risk score for you to estimate your risk. And for some patients, you might want to do a CT calcium score, but this is only in certain select patients who are at intermediate to high risk. And this will be covered in a separate talk on CT calcium scoring. So these give us much better information on your true risk profile than maybe some of the other tests you might see outside, like, for example, coronary angiograms or various other kind of stress tests. So let me just come back to this. The most important thing is looking for the cardiovascular risk factors, or as we abbreviate them, CVRF. And it does make sense because if you want to prevent the bad outcome, at the end of the day, you should be looking for the underlying root causes of this outcome. So that's smoking, diabetes, cholesterol, and high blood pressure. And control over these main factors is the best thing that you can do to prevent death and heart attack, especially if you're asymptomatic at this point in time. And it's been proven by multiple studies. So you need to know how you're doing or what really matters, the underlying drivers of the buildup of fatty plaques. And these are the things that actually you can target, and these are the things that actually matter. And I want to talk about this concept of false reassurance. So say you do a scan and it tells you that actually you don't have severe blockage. Maybe you're like the man on the right, where you have many spots, all 30%, but nothing severe or significant. Does that mean that you're safe and you can stop all your medications and you can just eat whatever you want for the next year? Well, maybe not. Maybe I think it's important to ask yourself and really examine why you're doing these tests. Are you doing this test to falsely reassure you and to say, oh, hang on, I don't have any of these severe coronary artery blockages, then I'm fine? Well, if you really want to avoid any problems, you need to actually control the underlying risk factors and put in the hard work to do that, and not just falsely reassure yourself with all these yearly tests. So we come to this concept of primary prevention, which is if you're asymptomatic at this point in time, what you really can do to lower your risk of heart attacks. So that's controlling your cholesterol, controlling your blood pressure, doing appropriate physical activity, using aspirin if indicated, having diabetes, controlling your diabetes, your eating healthily and stopping smoking. So let's look at what the guidelines themselves say. So the guidelines say that actually you should, whenever you have the opportunity to screen for these cardiovascular risk factors when you see a doctor, you should do that. And it's the same. You should, as it says here in this table, opportunistic screening for healthy individuals of all your cardiovascular risk factors and to use the appropriate scoring system to estimate your risk. So again, when you see a doctor, these are the things that you should be looking out for. So finally, we come to the take-home messages. If you have no symptoms right now, there is no strong evidence for you to have routine screening for obstructive coronary artery disease, for example, with an invasive coronary angiogram or even with a CT coronary angiogram. And instead, what you should be looking out for is your cardiovascular risk factors. And that's, once again, things like your age, which unfortunately we can't change, but your diabetes, cholesterol, high blood pressure, and smoking. And if you control these things and lead a healthy lifestyle, that is the best way and the only proven way for you to reduce your risk. Thank you.